I have worked on MRD for many years. I have done it for over 15 years, 15, 20 years perhaps. My first observations were that with the best drugs we had when I worked at the NIH, we could achieve complete response or remission in a very high proportion of our patients. And I was contemplating the day every patient is in remission, we don't have to test anymore, because if we already know everyone is in remission, we don't need, it's kind of a waste of time. But I was also wondering, maybe we should go beyond remission and see if there are residual cells. So we started drilling deeper into that. We started working in the bone marrow. We started working in the blood. We set up a lot of flow assays. We also set up sequencing assays. We didn't really know exactly how to do it at the time. We ended up sequencing the VGJ region, which is the switch region that has been developed for tracking for sequencing-based MRD testing over time. Our first tests were way more primitive, and we worked with a lot of collaborators around the world. We now have technologies that are even FDA cleared. We have the clonoSEQ assay by Adaptive Biotech that is an approved assay here in the United States. And there are also flow assays that have been set up by groups. We and others have set up a lot of assays for that. The FDA approved, or ODAC approved, I should say, on April 12 of 2024, MRD as an accelerated early endpoint for accelerated approval for multiple myeloma. So ODAC voted 12-0 in favor of that. That's now handed over to the FDA to implement that. So it has not yet fully been implemented, but ODAC voted 12-0. All these things I'm talking about are basically technology has led us to show that you can find residual disease in some and not in others. It is associated with better prognosis to be free from disease. And ODAC voted that you can use this as an early endpoint for accelerated approval. These are all drug development perspectives. The question you're asking me about using it as a tool for treatment decision is actually a very, very different perspective. It has really nothing to do with drug approval, drug development. It's just as a tool, as a clinician, where you could basically think of, you put your foot on the gas pedal, you press a little bit harder, or you take the foot off the gas pedal. That's what it's all about. I think that is going to happen more and more, but the way I think about it is that blood-based tests will probably be necessary for that to really happen. It's not feasible in my mind to having to do a bone marrow biopsy every time to determine whether you should increase or decrease the speed or the intensity of the treatment. So if we have soon blood-based tests, I think very soon people will start thinking about going up and down in the intensity. And you could think about, say a patient gets some of the new combination therapies, there is no evidence of any adverse biology really, there is no high-risk disease, however we like to define that. Probably many of those patients will not be transplanted, I think, in the future. And you will continue to monitor the patient over time. And you can maintain the patient on maintenance therapy and ensure that the patient remains MRD negative. For patients that have residual disease, maybe you will then decide to do additional therapy. Maybe transplant will be in the future, maybe CAR T cells could be in the future, or maybe bispecific antibodies could be in the future, or other therapies. I think we will see a development of a lot of different options. And I also think for patients who are on maintenance therapy, if you have been on a combination, eventually you end up on one drug. For many years you stay on. If there's a blood-based test for MRD, if you convert from negative and you become positive, I think that could be a trigger to think about maybe stepping up the intensity of the treatment, maybe add some other antibody or something to drive down the disease again. And I think you can probably clear out the disease in many patients, and you maybe can step back again, or you can switch from one approach to the other. So I think MRD will have a very important role in the future. It's going to be very hard to do trials to answer all these questions. A lot of this will be also driven by just clinical judgment and expert experience. But there will be trials for sure, and there are trials in development, but there are probably many more questions than there will ever be trials that can cover.